When I have a patient with HER2-mutated non-small cell lung cancer, advanced HER2-mutated non-small cell lung cancer in my clinic, I certainly do take that into consideration when I'm selecting treatment right from that first line of therapy. Currently, in early 2025, we only have one approved therapy for patients with HER2-mutated lung cancer, and that is trastuzumab deruxtecan, the HER2-directed antibody-drug conjugate. However, right now, this is only approved in the later line, the post-chemotherapy setting. So for a newly diagnosed patient, my preferred first-line therapy right now is still platinum doublet chemotherapy. I tend not to add immunotherapy for patients with known HER2 mutant lung cancer, particularly if these patients have little or no smoking history, as is often the case with HER2 mutant lung cancer. But I would say that decision about whether to use chemotherapy alone or chemoimmunotherapy should be individualized for each patient and discussed between the provider and the patient. When patients do develop disease progression on that first-line treatment strategy, I consider either clinical trial enrollment if a clinical trial is available for the patient, or second-line therapy with trastuzumab deruxtecan. But I will note that there's an ongoing study, DESTINY-Lung4, which is evaluating the first-line use of trastuzumab deruxtecan versus standard of care therapy, and I suspect that may change our standard of care in the frontline setting in the near future. So in addition to the ongoing trials really helping to inform the optimal placement of trastuzumab deruxtecan, we've also seen some exciting clinical trials now with HER2-directed oral tyrosine kinase inhibitors. This has been a space, of course, where we've seen a lot of clinical research over the years, but some of the prior agents have been limited in their clinical utility by the off-target effects that we see, the side effects that can be associated with inhibition of EGFR with drugs like pyrotinib and poziotinib. We did see activity in HER2 mutant lung cancer, but we also saw very high rates of diarrhea, and that limited their clinical utility. Now we are starting to see clinical trials of drugs that are mutant selective, so selective for HER2 mutant lung cancer and sparing of EGFR. The one of these that's furthest along in clinical development is the drug zongertinib, which has shown promising activity in the phase 1 BEAMION-Lung01 trial. In that study, we saw response rates over 70% at the different dose levels tested, including some early evidence of intracranial activity. In terms of safety profile, we did see some diarrhea and rash, but fortunately, grade 3 or greater toxicities were generally uncommon. So I think zongertinib is certainly a promising agent in this space and one to keep an eye on. But we've also seen some reports of activity with others. Notably, we saw some promising results with BAY2927088, which is another HER2 tyrosine kinase inhibitor. In the SOHO-01 study, we saw an impressive response rate of 72% across HER2 mutant cancer. And in particular, in patients with that most common YVMA exon 20 insertion, the ORR was 90% in a small cohort of patients. So really encouraging activity there. But notably with the Bayer compound, we did see somewhat higher rates of diarrhea, including about a quarter of patients having grade 3 or higher diarrhea. So we'll have to see how that balance of efficacy and safety plays out with this compound.